going through our claims that are out there. And Dr. Malam's and I's objectives are to challenge these claims with the science that's out there. Okay? So one of the claims is that with immediate implant placement, there are opportunities for ICU integration are better due to the healing potential of the extraction socket. And since this is Dr. Malayam's expertise, he's going to give you a little bit of information about how a socket that you've just had an extraction from is different from a socket that's created with delayed placement.
So this is a histological slide. Basically, that's the buccal, the lingual. You can see to begin with, at 8 weeks, you have such a thinner buccal bone. To begin with, you have a thin buccal bone, but afterwards, it gets even thinner. You can see the buccal tissue, how much more apical it is to the lingual. Now, if you're talking about the maxilla, this lingual or palatal is your palate. The palate, by definition, has keratinized tissue, very thick. The thicker the tissue, the less likely the bone is going to resorb, and vice versa. The thicker your bone, the less likely your tissue is going to resorb. So that's why we have thicker tissue on the palate. We don't get a lot of resorption on the palate. Our main concern is always the buccal, and the way we were created, it's our buccal that's visible to people, and that's our thinnest part. So we have to do certain things and keep in mind when we're doing these cases how to treat and select the patient. For example, if a patient comes and they have a very big smile line, so everyone could see their gums, now all of a sudden, and they have thin tissue, when you take out their tooth and place an implant, you might get a little bit of recession. Okay, those are the kinds of things that you have to look out for. But if it's a 60-year-old, male, he smiles, you don't even see any, barely any teeth, he has a mustache, it's covering everything. In fact, he says, when you take out his tooth, I don't need a temporary. We all see those guys. I don't want a temporary. Those are the kind of people that you want to, treat. But unfortunately, not everyone is like that. Again, rule of thumb, numbers. Whenever you take out a tooth, you're going to lose about 2, 3, 4, maybe 4 millimeters of bone height, and then a couple of millimeters of bone width. It's expected. And it's because mainly of what we talked about, the thickness of the bone, and that's going to, that's why when you when you do extractions and you want to give a temporary to the patient, like a denture, in a few weeks or a month, the denture is rocking because you're having a lot of bone resorption. And the fastest resorption rate is in the first 6 months. Okay? After 2 years, the rate is much slower and more moderate. Why is that? Why after 2 years it slows down? Does anyone know what happens at 2 years? So basically at 2 years, the bone in the jaw is completely different than the bone that it was there 2 years ago. There's a complete turnover of bone after 2 years. Okay. When you do a bone graft and place bone, like freeze-dried bone, cadaver bone, that takes about 4 months for that to resorb. Okay. So patients always ask, what kind of bone are you placing? What is that? And you say cadaver bone. They say, that dead people's bone? People get scared. You have to always reassure them that this bone is going to get broken down eventually to carbon dioxide and water, the most simplest forms your body breaks it down to. And anyways, in 2 years, this bone is going to be completely different bone than it's there. So that's why at 2 years we have a slower rate, because it lost its memory of that previous extraction. It's completely new bone. After also the first year, you get a 50% decrease in bone width. This is according to this study in 2004. Saying 4 millimeters of bone height after a year, of which 2 months of it lost in the first 2 months, and then 2 more during the first year. So if you ever want to make a restoration in this area, you always want to wait until it's done most of the resorbing. That's why we want to wait definitely after 2 months and somewhere in between the first year, maybe 4 months, 6 months. And having said that, the thinner the tissue, the more resorption you're going to get. The thicker the tissue, the less resorption. Again, now this is showing when the implant is there. A lot of times, look at what you're dealing with. You have maybe threads exposed. This is an immediate implant in a fresh extraction socket. Bone is going to do its thing, but if you're going to put in like a temporary or an implant or a healing abutment even, it's going to support your soft tissue, which is really important because then you don't have your papilla falling down and becoming flat. Look at this picture right here. Just by looking at this, would you say this is a thin or thick tissue? Thin? Okay. I would say this is a little bit, on this view, it's showing a little bit of thickness actually, of tissue. I'm also looking at the keratinization. You see how it's nice and white? You don't have a dip. Okay? Again, you can't tell what it looks like on apical. There might be fenestration, or you can't even tell the bone, but this is not so bad, the tissue here. So a lot of times this is what we see. When you're doing an immediate, okay, we want to try to do a flapless, so without laying a flap. These days, they're making the claim that if you do a flap on the buccal, that it's very barbaric, and you're going to lose a lot of tissue and get recession. So we try to access everything for elevation with periotomes, very thin periotomes, coming in from the palatal side, okay? Periotomes are very thin, and they get in between the socket, and by rocking motion on each side, it loosens up the tooth, okay? And if you're dealing with a root, then you're going to need, maybe root forceps, and then I go in with something that's a little bit more convex or concave to elevate it out. So very slowly, atraumatic extraction is necessary. Also, if you're not going to flap, once you take out the tooth, you may not be seeing the dehiscence or fenestration that might be more apical. So you have to get your explorer or probe and go in and see, as you go through this into the socket, you take your explorer and you see if your tissue moves, and you basically rub it all along this, and if you see all of a sudden your tissue's coming out, then you know that there's a perforation or fenestration. Then you may want to flap, okay? Because I've seen a lot of patients have bacterial issues, and it's kind of like an endolesion, and very easily you could graft that, and then place your implant and then graft that area, or you can just bone graft it, membrane, and wait until it heals and then place your implant later.